It's located below the mandible. Sub, it means below. So it's located below the mandible in the submandibular triangle of the neck. Now on this slide, the picture on the right side shows the base of the mandible. Here you see the skin has been removed from here. This is the investing layer of fascia. And this is the neck where we have removed the skin, the superficial fascia and the deep fascia of the neck from the surface of the submandibular triangle. This is the submandibular triangle bounded by the base of the mandible, the lower border of mandible. Then here we have the anterior belly of digastric, and behind and deep here comes the other belly of digastric, which is the posterior belly of digastric. The submandibular salivary gland is contained within this triangle. The submandibular gland, it's formed of two parts, it's formed of two portions, a superficial part which lies outside the oral cavity in the submandibular triangle, and it's continuous with a deep part, which is on the left side here, this one. On the left picture, this is the deep part of the submandibular gland, which lies over the mylohyoid muscle. So again, it's inside the oral cavity, which is the deep part of the submandibular salivary gland, or the smaller part of it. The two parts are continuous with each other at the posterior free border of the mylohyoid muscle. So the superficial part lies on the mylohyoid and then turns to become the deep part over the posterior free border of mylohyoid into the oral cavity here, into the oral cavity. This is the cuttage of the mylohyoid muscle, and the deep part lies inside the oral cavity. Now the superficial part is the larger part of the submandibular salivary gland. It looks like a wedge shape, has three surfaces, a superficial, which is this one, which is shown here, and then a superomedial surface and an infерomedial surface. The superficial surface of it, it's covered with skin, with superficial fascia containing the platysma muscle, and then contains the deep fascia, which is the investing layer of deep cervical fascia, and then we come to this surface. Over this lies the submandibular lymph nodes here, together with this facial vein, passes superficial to it. Only the facial vein, not the facial artery, with the cervical branch of facial nerve, which cut here and supplies the platysma muscle. These are the relations of its superficial surface. The superomedial surface of it. The superomedial surface, this lies over on the mandibular fossa of the mandible line, as related to the submandibular fossa of the mandible below the mylohyoid line. The infерomedial surface is related to the infrahyoid, to the inferior surface of mylohyoid muscle, inferior surface of mylohyoid, and nerve and artery to mylohyoid with submental artery and the facial artery. The facial artery passes deep to the superficial part of submandibular gland, while the facial vein passes superficial to it. So as it is enclosed by the artery and the vein, the artery comes from here and then passes deep to the submandibular and emerge at the base of the mandible to ascend into the face, where you can feel the pulsations of facial artery here at this point. So these are the relations of the superficial part of submandibular gland. This portion becomes continuous at the posterior free border of the mylohyoid to become the deep part. The deep part lies here over in the floor of the oral cavity above the mylohyoid muscle, and from it emerge the duct of the submandibular gland. This portion, the deep portion, is related to the floor of the oral cavity, and it's covered by mucous membrane, which has been removed from it. This is the cut edge of the mucous membrane of the oral cavity. To the deep part of submandibular gland, superior to it passes the lingual nerve, which is this one, and the submandibular ganglia, and the submandibular ganglia, while the hypoglossal nerve lies below it as it enters into the oral cavity. Now, the duct of the submandibular gland. The duct of the submandibular gland, this emerges from starts at the superficial part and then passes through the deep part. Emerging from the deep part, it's about 5 centimeters in length and ascends upward to enter into the sublingual salivary gland. Enters here in the sublingual passes inside the sublingual salivary gland in the oral cavity, and is crossed here by the lingual nerve. Then passes inside the sublingual salivary gland, and then here on this slide on the right side, you see this is the oral cavity. Oral cavity opened. This is the inferior surface of the tongue. The tongue has been elevated. Some of the mucosa of the inferior surface of the tongue has been removed to the mucosa and the floor of the oral cavity. You see here in the floor of the oral cavity, this elevation, this is called sublingual fold. It's due to the presence of the sublingual salivary gland. Some of the parts has been removed on this side with the mucosa to see the duct of the submandibular gland. The duct of submandibular gland, so from the superficial part, ascend and crosses within the deep part and emerge on the floor of the oral cavity to enter inside the sublingual gland. Here enters inside sublingual gland and then comes to open over the summit of the sublingual papilla. Sublingual papilla, see this is the minute opening of the submandibular ducts, opening in the summit of this sublingual papilla. As it passes through the sublingual gland, it takes some of the ducts of the sublingual salivary gland, opens in it also, and then opens in the summit of sublingual papilla with a minute opening. You can see it on yourself when you elevate your tongue and look to the mirror. You will see this sublingual papilla on each side of the frenulum of the tongue. This is the frenulum of the tongue. On each side are the 2 sublingual papillae, and on the summit of these sublingual papillae is the opening of the submandibular duct. So the submandibular duct, again the drainage of it, because the gland lies below the oral cavity, then it should be against the gravity, needs pressure to be powered into the oral cavity. The duct is about 5 centimeters and is crossed by the lingual nerve in the floor of the oral cavity. This is for the submandibular gland. The blood supply of the submandibular gland is by the branch of the facial artery, the submental branch, and the nerve supply to it, sensory nerve supply is from the lingual nerve, and the parasympathetic supply is from this ganglia, submandibular ganglia. It gives branch to the submandibular gland. It's secretomotor for the gland, so stimulation of parasympathetic lead to secretion of saliva. When you smell food or eat, then this will be stimulated, leading to powering of saliva into the oral cavity. And the submandibular ganglia receives preganglionic parasympathetic fibers from chorda tympani through the chorda tympani of facial through the lingual nerve. We will come to these later. We will study these, but the parasympathetic supply is from the submandibular ganglia, which is secretomotor. Sympathetic supply is from the plexus around the lingual artery here, supplies the submandibular ganglia from superior cervical sympathetic ganglia, which is inhibitory to the gland. The submandibular gland is a mixed gland, is a mucus. While we have seen that the parotid is only serous, this one is mixed gland, is mucus. Again, submandibular glands, two of course, irregular in shape, size of a walnut, smaller than the parotid. Two parts, superficial large and deep small, continuous with each other at the posterior border of mylohyoid muscle. It's mixed mucus. Superficial part lies, as I said, in the digastric triangle. It's partially enclosed by deep cervical fascia with stylomandibular ligament, separating it from the parotid gland. One layer covers its inferior surface and the other attached to the base of the mandible. Other covers its medial surface attached to mylohyoid line. Forms a false capsule for the submandibular salivary gland. Just like the parotid, you have seen that it forms a false capsule, the investing layer of deep cervical fascia, for the parotid gland. With the stylomandibular ligament, which is a thickening of this investing layer of deep cervical fascia between the styloid process and the angle of the mandible, forms a line of separation between the two glands. Submandibular superficial part has three surfaces, inferior, lateral, and medial. Inferior surface, which is the superficial surface, covered with the skin, platysma, deep fascia, and is crossed by facial vein. Cervical branch of facial nerve with submandibular lymph nodes lies on it or embedded within the gland. And lateral surface or inferior-medial is related to the superior-medial is related to the submandibular fossa of the mandible, just below the medial pterygoid attachment. Facial artery grooves the posterior superior part before it passes above the base of the mandible to enter in the face. The medial related anteriorly to the mylohyoid muscle, or the mylohyoid nerve and vessels and submental vessels, branch intervening. Posteriorly is related to the styloglossus, stylohyoid ligament, and glossopharyngeal nerve. And its medial part is related to the hyoglossus, lingual nerve, hypoglossal nerve, and deep lingual vein. The deep part is continuation of the superficial part behind the free border of the mylohyoid, extends forward to posterior end of the sublingual gland, lies between the mylohyoid inferiorly and hyoglossus and styloglossus medially. Above it runs lingual nerve with submandibular ganglia, and below is the hypoglossal nerve and deep lingual vein. You can palpate the submandibular glands between an index finger placed on the floor of the mouth. You can put now your index finger in the floor of your mouth and the thumb placed below the floor, anteromedial to the angle of the mandible. And then you can palpate it between these two fingers, between the thumb and the index. You can palpate the submandibular salivary gland. Try it on yourself and you can palpate the submandibular salivary gland. A duct of the submandibular gland, as I said, it's 5 centimeters long, begins in superficial part, then emerges from its behind posterior border of mylohyoid, traverses the deep part, and then passing up and slightly back, then forward between mylohyoid and hyoglossus, passing between sublingual gland and genioglossus. It opens in the floor of the oral cavity on the summit of sublingual papilla at the sides of the frenulum of the tongue. On the hyoglossus lies here, you see the lingual nerve with the submandibular ganglia lying above it. Hypoglossal nerve lies below it. The anterior border is crossed, the duct is crossed by this lingual nerve. Blood supply arteries, branches of facial and lingual. Vein correspond to the arteries. Lymphatics drain to the submandibular lymph nodes, and from there to the upper deep cervical lymph nodes. Nerve supply, sympathetic plexus around the facial lingual arteries is inhibitory from the superior cervical sympathetic ganglia. Parasympathetic, it's from submandibular ganglia, secretomotor for the gland. Excitatory leads to secretion of saliva. Preganglionic parasympathetic from the chordae tympani or facial, and sensory nerve is supplied by lingual nerve. Now, what is left is the third pair of large or major salivary glands, and this is the sublingual glands. Now, the sublingual glands are the smallest of the three. It's totally mucus, and this can be seen covered with mucous membrane in the floor of the oral cavity. It lies totally within the... Now, sublingual salivary gland is the smallest of the three glands and lies totally within the oral cavity. It lies in the sublingual, over the sublingual fossa of the mandible, which lies above the mylohyoid line, so it rests over the mylohyoid muscle, and it's covered with mucous membrane. It's covered with mucous membrane. Here you see the mucous membrane has been cut from here over it to show it, and here it forms a fold in the floor of the oral cavity on each side. If you raise your tongue, you can see the frenulum of the tongue in the center, and then on each side of it, a fold of mucous membrane raised, passing laterally from the frenulum of the tongue. This is called the sublingual fold, and this is caused by the presence of sublingual salivary gland. On the medial end of it is the sublingual papilla, which we said contains the opening of the submandibular gland. So inferiorly is related to the submandibular fossa of the sublingual fossa of the mandible, and rests over the mylohyoid muscle, covered superiorly by the mucous membrane of the oral cavity. This is the sublingual salivary gland. The ducts of the sublingual salivary gland, the number of them, it's variable, have multiple ducts from 8 to 20 ducts. Some of them, they open directly into through minute openings. You see the have raised the mucosa from here, and you see these are small minute ducts of the sublingual gland, which open directly into the floor of the oral cavity. Some of the ducts join the duct of submandibular gland and open with it into the summit of sublingual papilla. As I said, the sublingual is totally mucus secreting saliva. Again, the blood supply of it is through the branch of the lingual artery, the sublingual branch of lingual artery. The veins accompany the arteries. The sensory nerve supply is through the lingual nerve. The parasympathetic, again, is from the submandibular ganglia, where branches from it join the lingual and come to supply the postganglionic parasympathetic, which are secretomotor to them. And the sympathetic is again from the plexus around the lingual artery from superior cervical sympathetic ganglia, which is inhibitory. So the three parasympathetic glands, all they receive, the salivary glands, parotid, submandibular and sublingual, they receive parasympathetic supply, which is secretomotor, and receive sympathetic supply, which is inhibitory for their secretion. The parotid receives parasympathetic from otic ganglia, while the other two, submandibular and sublingual, they receive it from the submandibular ganglia. The sympathetic supply for all of them is from superior cervical sympathetic ganglia. Sensory supply for both submandibular and sublingual is lingual nerve, while for the parotid is auriculotemporal nerve. Again, they are smallest, lie beneath oral mucosa, each in contact with sublingual fossa of mandible. It's narrow, flat, shaped like an almond, about 3 to 4 grams, is mucus in type. Above it is covered with mucosa, oral mucosa, raised as sublingual fold. Below is the mylohyoid. In front, its anterior end of its fellow on each side of the frenulum of the tongue. Behind lies deep part of submandibular gland. Medially is genioglossus and separated from it by lingual nerve and submandibular duct. The sublingual ducts has 18 to 20 secretory ducts, small, mostly open on the summit of sublingual fold separately. Few open in the submandibular duct, continues with it from anterior parts. Small rami sometimes form a major sublingual duct. This is rare, forming a single duct opening in or near the orifice of submandibular duct, but usually some of them they open separately and some connect with the submandibular duct. Vessels, arteries, as I said, sublingual, submental arteries. Veins correspond to arteries. Nerves, sympathetic plexus around facial and lingual is inhibitory. Parasympathetic submandibular ganglia is secretomotor, and sensory is lingual nerve. Now, testing for the salivary glands, we use radio-opaque material. We inject radio-opaque material, مواد opaque بالأشعة تطلع opaque تطلع بيضة. We inject these material through the openings of the ducts, for example, for the parotid or for the submandibular. We inject through the opening of the duct and then take an X-ray. This process, we call it cyanography. Cyanography, it means taking X-ray of the salivary gland ducts with using radio-opaque material. This is identifies obstructions or narrowing in the ducts of the salivary glands due to any cause, due to stone formation, calculi, حجارة تصير بها, calculus or stone, if it is due to inflammation, due to infection by bacteria or viruses, or sometimes due tumors of the duct and the gland leading to obstruction. These we can detect abnormalities in the ducts by this process. And the most commonly affected by obstruction is the submandibular duct. This is because the gland lies below the floor of the oral cavity, and then the saliva should pass upward against gravity to enter into the floor of the oral cavity. This might lead to some stasis, and accumulation of debris usually leads to formation of calculi. And to less extent occurs in the ducts of the parotid gland. And in such cases, when there is obstruction or narrowing of the lumina of the duct, the patient, he will come to you and he will tell you that whenever he eats food, he will feel swelling in the submandibular region. And then this swelling fades away after 2 to 3 hours after meal. This is because of obstruction. The saliva remains inside, because once you eat food, there will be secretion of the saliva, and if the duct is obstructed, it remains and leads to dilatation of the duct, and the ductules and the alveoli of the gland lead to swelling of the gland. And if it stops eating, then secretion will be decreased, and then this will be absorbed by 3 to 4 hours, and then the swelling diminishes. So from the history from the patient, you can diagnose narrowing or obstruction in the duct of the submandibular gland or the parotid gland. Now, sometimes we have mumps. It means nikaf. Mumps yani nikaf. Nowadays, it has become rare because most of the children after birth, within 3 to 6 months after birth, they are given the vaccine اللقاح ضد الممس اللي يسميه اللقاح الثلاثي. mumps, measles and rubella نسميه MMR هو ضد النكاف والحصبة الألمانية. Mumps is viral infection of the salivary glands, usually affects the parotid gland. The parotid become enlarged and become painful, and if you look to the inside, even before enlargement of the gland, the duct opens at the summit of the parotid papilla opposite the upper second molar tooth. With the beginning of mumps, if you look to the oral cavity, to the vestibule, you can see redness and swelling of the opening of the parotid ducts, and it becomes tender when you palpate it. Then the patient will feel pain on palpation. This is mumps, and usually affects the parotid, but might affect the submandibular and sublingual glands. Nowadays, it's rare because most of the people, they have the vaccine, and once they get the vaccine, they will not get the viral infection or the mumps. Abscess and parotid glands. Sometimes this might result from extremely poor dental hygiene. Poor dental hygiene of lot of infections in the oral cavity tooth might pass through the ducts of the parotid gland and then to inside of the parotid and lead to infection of the parotid, lead to accumulation of pus. القيح أو خراج inside the parotid gland. And surgery on the parotid gland, it's very difficult because we have seen that within the parotid gland lies a lot of structures. We have seen that contains nerves, facial and auriculotemporal, contain arteries, the external carotid, maxillary, and the superficial temporal artery with the retromandibular vein. So it's very difficult to operate on the parotid gland. You should be very careful not to injure these nerves and vessels. Sometimes when there is complete obstruction of the duct of the submandibular gland due to tumor, or then you cannot remove it, you should remove with it the submandibular gland in cases where there is cancer. And excision of submandibular gland is an easy process. The incision should be made at least 2.5 centimeters below angle of the mandible to avoid mandibular branch of facial nerve, because it passes superficial to it. So this is for the major salivary glands, and we said that the oral cavity contains, in addition to these salivary glands, contains the minor salivary glands, which are minute glands, and these they open by separate openings into the mucosa of the oral cavity. Now we have finished with the contents of the oral cavity. We said that contains the tongue, the salivary glands, Now you will study the muscles of mastication, since these are related to the oral cavity, and they are responsible for movement of the mandible. If you remember from last year, we have studied the mandible, that the ramus of the mandible receives all muscles of mastication. Now, muscles of mastication are four pairs of muscles. These are temporalis, masseter, lateral, and medial pterygoids. Lateral and medial pterygoids. Now, generally, all the muscles of mastication, they have general features. All are derived embryologically from the first pharyngeal arch. I don't know whether you have studied in the embryology these things, the pharyngeal arches. All of them are supplied by the mandibular nerve, which is the nerve of the first pharyngeal arch, which is a branch of the trigeminal nerve, the fifth cranial nerve. All of them arise from bones of the skull, and they are inserted, all of them, into the ramus of the mandible. All insert into the ramus of the mandible. Two rami of the mandible, each of them receives 4 muscles of mastication. So these are common features for the muscles of mastication. And the 4 muscles of mastication, the main action of them, they are masticatory muscles. They act over the temporomandibular joint, leading to movement of the mandible, and so movement of the teeth aid in masticating food. Now, the 4 muscles, as I said, are the temporalis, the masseter, medial, and lateral pterygoid muscles. You'll start first with the temporalis muscle. The temporalis muscle, the largest in size of the all 4 muscles. If you look to it, it looks like a fan. مثل اسمه المروحة المنضدية. Looks like a fan. It's covered with temporal fascia. This is the temporal fascia. This is the cut edge of temporal fascia, which is attached to the superior temporal line. This is the side of the skull. We have removed the scalp, layers of the scalp, to see the temporalis muscle. Here is the zygomatic arch. This is the ramus of the mandible. This is the zygomatic bone, and this is the temporal mastoid part of temporal bone with the greater wing of sphenoid here, and the ramus of mandible. Now, the temporalis muscle looks fan-shaped, have different directions, the fibers of it. It arises from the deep surface of the temporal fascia, from the floor of the temporal fossa. Now, the anterior fibers, they run downward and vertically to be inserted into the ramus of the mandible. They insert to the coronoid process and anterior border. Here you see anterior border of the ramus of the mandible. It passes, the tendon of it pass medial to the zygomatic arch and then insert into the coronoid process and anterior border of the ramus of the mandible. Anterior fibers run directly downward. So contraction of these fibers, it will elevate the mandible. The other fibers, they run obliquely downward and forward, and the most posterior fibers, they are more or less transverse. You see the direction of these fibers. So these fibers, posterior fibers, when they contract, they pull the mandible backward. So they retract the mandible. They retract the mandible. So the temporalis muscle, action of it, according to the direction of fibers, the anterior fibers, it raises the mandible, so closes the oral cavity, the oral fissure or the fissure between the teeth, leading to occlusion of the teeth. The posterior fibers, they pull the mandible backward, so they retract the mandible, pulling it backward after its protrusion. The nerve supplied to the temporalis muscle are the temporal branch from the mandibular nerve, from the anterior division of the mandibular nerve. Usually there are two passing on the deep surface, sending from the infratemporal fossa, pass on the deep surface of the temporalis muscle, supplying it. As I said, all the muscles are supplied by mandibular nerve, and this branch to the temporalis muscle, we call it deep temporal nerves, one or two, supplying the temporalis muscle. So temporalis, the origin, whole of temporal fossa, deep surface of temporal fascia, inserted. Fibers converge and descend into a tendon, which pass in gap between zygomatic arch and side of a skull and attached to medial surface, apex, anterior and posterior borders of coronoid process, and anterior border of ramus almost to the last molar teeth. The anterior fibers are oriented vertically, the most posterior fibers almost horizontally, intervening fibers with intermediate degree of obliquity in a manner of fan. Because of tough temporal fascia, it's difficult to palpate it, but when it contracts, if you clench your teeth, then it can be easily felt. Its upper limit can be made along the inferior temporal line with teeth are firmly clenched. Relation superficially is covered with the skin, auricular muscles, that's part of the scalp with temporal fascia, auriculotemporal nerve and temporal branch of facial, zygomatic and masseter, zygomatico-temporal nerve and epicranial aponeurosis. All these are within the layers of the scalp. Deeply is the temporal fossa, lateral pterygoid and medial pterygoid lies deep to its tendon. Lies over the buccinator and maxillary artery with deep temporal arteries and nerves supplying it. Posteriorly is masseteric nerve and vessels, anteriorly separated from zygomatic bone by a mass of fat. Nerve supply is deep temporal branch of anterior division of mandibular. Action, as I said, elevates mandible, so closes the mouth, approximates teeth, contributes to side-to-side grinding, and posterior fibers, they retract the mandible. Now we pass to the masseter. Next, the masseteric muscle. Here you look to this slide, the masseteric muscle is this one. This is again the zygomatic arch, this is the temporalis. Here are the scalp muscles, the auricular muscles. The auricle has been removed from here. This is the zygomatic arch, this is the zygoma, zygomatic bone, the maxilla, the mandible with the buccinator, and this is the ramus of the mandible, and this is the temporomandibular joint and external acoustic meatus. Here is the masseteric muscle covering the ramus of the mandible from the outer surface. The masseteric muscle arises again from the zygomatic bone and from the inferior border of the zygomatic arch, formed of two portions, the superficial and the deep part. A deep part, which is this one, arising from the internal aspect of the inferior border of the zygomatic arch. The superficial part arises from the zygoma and the outer border of the inferior surface of the zygomatic arch. The fibers of it descend downward and backward, while those of the deep part, they descend more or less vertically and be inserted on the lateral surface of the of the ramus of the mandible. So the anterior or superficial fibers of the masseter, if they contract, what they do, they retract the mandible and elevates upward. The vertical fibers, they elevates more straight, elevating and pulling it backward. The masseter is supplied by the masseteric nerve, which is again branched from the anterior division of the mandibular nerve. And the supply is by masseteric arteries from the second part of the masseter is covered, of course, here by skin, superficial fascia, and the parotid gland lies over it with the investing layer of cervical fascia with the transverse facial artery. All these lie superficial, deeply. It forms the lateral wall of the infratemporal fossa. Masseter, so is quadrilateral, consisting of 3 layers which blend anteriorly. Superficial is the largest, from the maxillary process of zygomatic bone, anterior 2/3 of inferior border of zygomatic arch, insert fibers downward and backward at the angle and lower posterior half of the ramus. Middle layer, origin, medial aspect of anterior 2/3 of zygomatic arch, lower border of posterior third, insert into the central part of mandibular ramus. The deep part, origin from deep surface of zygomatic arch, insert into the upper part of ramus, coronial process. Middle and deep parts, they form cruciate muscle. Take considered in most of the books as one part, the middle layer and the deep layer. Related to it, superficially is covered with the skin, platysma, rhizolius, parotid gland, duct, facial nerve, and its branch, or transverse facial artery. Deeply lies over ramus and temporalis, with the masseteric nerve passing over the mandibular notch to the deep surface of the masseteric, supplying it. Posteriorly is overlapped by parotid gland, and anteriorly projects over buccinator crossed by facial vein. Nerve supplied by masseteric nerve from anterior division of mandibular gain. It elevates mandible to occludative, minimal effect in side-to-side movements, protrusion and retraction. Next, we pass to the pterygoid muscles. We have 2 pterygoids, the lateral and medial pterygoid muscles. Now, in this slide, to the medial aspect, to the right, is the medial pterygoid muscle. Now, here is the zygomatic bone. This is the maxilla with the buccinator muscle. This is the body of mandible. The ramus has been cut from here. The zygomatic arch has been cut with the ramus of mandible together with the masseter, and the temporalis muscle has been removed to pass inside the infratemporal fossa. Here is the inside of temporal fossa, the TM joint. So the mandible is removed, and then the head of the mandible also is removed, to see the internal structures in the infratemporal fossa. This is the lateral pterygoid plate. This is the pterygomaxillary fissure here, and this is the posterior border of maxilla. Now, the medial pterygoid muscle lies totally within the infratemporal fossa. It arises from the medial surface of the lateral pterygoid plate. It has 2 heads. Another head arises from the posterior aspect of the maxilla and partly. So these 2 heads the fibers descend downward and backward to be inserted to the inner surface of the ramus of the mandible from the medial aspect of the angle that is opposite the masseteric muscle. The masseter is to the outer aspect, while the medial pterygoid is to the inner aspect or inner surface of the ramus of the mandible. The medial pterygoid is one of the contents of the temporal fossa. Usually the maxillary artery passes over it. The medial pterygoid is supplied by the nerve to medial pterygoid from the trunk of the mandibular nerve. And the artery is from the muscular branch from the maxillary artery. The medial pterygoid muscle, so is attached here. What it does, it retracts the mandible with the contraction. It opens the mouth and retracts the mandible. This is for the medial pterygoid. Now what is left is the lateral pterygoid muscle. the lateral pterygoid muscle. This arises by two heads. It's the smallest of the four muscles of mastication in size. The largest is temporalis, followed by masseter, then medial pterygoid, and lastly, the smallest of all is the lateral pterygoid muscle. Arises by two heads. One head arises from the lateral surface of the lateral pterygoid of the medial pterygoid lamina, and the other arises from the infratemporal surface of the greater wing of sphenoid. Here is the greater wing of sphenoid from the infratemporal surface and from the lateral pterygoid lamina. The two heads pass backward, and downward, and unite with each other to form a small tendon, which is attached to the pterygoid fovea, which lies in the anterior aspect of the neck of the mandible. The lateral pterygoid again lies totally within the infratemporal fossa. The maxillary artery usually passes either superficial or deep to it, and the mandibular nerve with the otic ganglia all lies deep to that. This is the mandibular nerve and the branch. It lies deep to it, and then in branch of it emerge from below it. Again, they're supplied by the branch from the anterior division of the nerve to lateral pterygoid from the anterior division of mandibular nerve. The action of the lateral pterygoid passes from here forward, backward to the neck of the mandible. So contraction of it pulls the neck forward, so leads to protrusion of the mandible, and the upper fibers usually they lead to slight elevation of the mandible. Both medial and lateral pterygoid, when they act with each other, they lead to slight side-to-side movements of the mandible. So the lateral pterygoid muscle is short, thick muscle with two heads. Upper head from infratemporal surface and infratemporal crest of greater wing of sphenoid. Lower head from lateral surface of lateral pterygoid plate. Insertion fibers of both heads pass backward and laterally to be inserted into the pterygoid fovea with the articular capsule and disc of the M joint. Relations superficial to it is ramus, maxillary artery may be deep, tendon of temporalis and masseter. Upper part of medial pterygoid, sphenomandibular ligament and middle meningeal artery and mandibular nerve. Upper border, temporal masseter branch of mandibular. Lower border of it lies the branch of the mandibular, which emerges below it are the lingual, inferior alveolar, with the branch of the maxillary artery. Nerve supply, branch from anterior division of mandibular nerve. Upper head mainly involved in chewing, because it leads to side-to-side movement. Lower head mainly involved in protrusion and assists in opening the mouth, because it pulls the mandible forward, the head of the mandible. Now, medial pterygoid, this is a thick quadrilateral with a deep and superficial parts. Deep part origin from medial surface of lateral pterygoid plate, grooved surface of pyramidal process of palatine. Superficial part, origin lateral surface of pyramidal process and maxillary tuberosity. Insertion lies at first on inferior aspect of lateral pterygoid. Fibers descend posterolaterally and attached by strong tendinous lamina to postero-inferior part and medial surface of the ramus and angle as high as mandibular foramen, almost as forward as mylohyoid groove, opposite the masseteric muscle. Related to it are laterally ramus, from which is separated above its insertion by lateral pterygoid, sphenomandibular ligament, maxillary artery, inferior alveolar vessels and nerve. All these lie lateral to it and lingual nerve. Medial to it lies the tensor villi palatini with styloglossus and stylopharyngeus, separating it from superior constrictor of pharynx. Medial pterygoid is supplied by the mandibular nerve to medial pterygoid, which is from the trunk, while the other three all are from the anterior division of the mandibular nerve. It assists in elevating mandible with lateral pterygoid protrudes it. Alternating activity with both on sides with the lateral pterygoid and right and left muscles produce side-to-side movements, which are used to triturate food. يطحن ويرسل food.